Recording in
and also
progress.
Doppler frequency. As the time difference decreases, the Doppler frequency increases. So in this image, you can see the blood cell at an angle of theta with the beam, forming an angle of theta with the beam. So how do you calculate Doppler frequency? You can see a very tough physics formula, but you don't have to learn it. Just need to know the concept behind it. When the frequency of the emitted sound from a stationary source, which is our transducer, is fixed, like we're using a linear probe, so we have a fixed frequency like 12 megahertz, or a curvilinear probe, fixed frequency that is a 3 or 4 megahertz, and its inclination angle is known. I mean the theta is known, which,
तो
which
कैसे
should be kept which should be kept less than 60 degrees
हाँ
to
डायरेक्टली
avoid.
ऐसा करे कि समझ में आने हाँ
Can you kindly please mute yourselves?
हाँ कॉपी ऊपर कॉपी कर को फिर एडिट करे
पूरे क्लियर कर दे नीचे के
फिर मेरे को भेजी
ठीक है जानबूझ पूरे क्लियर करिए
So yeah. So the frequency of sound emitted from a stationary source, which is the probe, is fixed and its angle is known, then the Doppler shift can be calculated. So it depends upon the Doppler shift directly depends upon the transmitted beam, frequency of the transmitted beam, the velocity of the blood, the angle between the beam and the flow of the blood. It is directly proportional. You increase that, the Doppler frequency increases. It is inversely proportional with the speed of the sound in tissue. More speed of the sound, less is the Doppler frequency of the phase shift. I hope everyone's understanding this, because this is the main basis of your Doppler. Once you understand this, everything is a piece of cake. So the same example that I explained you before also, the object is at point A, you get a high frequency Doppler signal because the beam is aligned in the direction of the flow. As the object moves to point B, it produces a less frequency Doppler signal because it is moving away and the angle increases. The angle of inclination theta increases. At point C, it comes exactly towards 90 degrees. We get a poor signal or no signal also. Why is that? Because cos 90, as you remember in 10th class physics, cos in 10th class maths, cos 90 is zero. The whole Doppler shift becomes zero and there's no flow. And at point D, it is away from the probe, giving a high frequency negative signal. So how do you optimize your Doppler waveform? Doppler modalities are based on three fundamental principles. The first is moving structures change the frequency and wavelength of reflected sound waves. Okay? Second, analysis of components of reflected signals like the shift of frequency is measured in color Doppler and spectral Doppler. Shift in amplitude is measured by power Doppler. Color Doppler and power Doppler are pulsed techniques, whereas spectral Doppler can be pulsed or continuous. So how do you optimize? We have all these options in front of you. So in spectral pulse wave Doppler, they should be the best would be absence of fetal breathing and movements. It would be even better if you ask the patient to have a small spell of breath holding to avoid the disturbance in the waveform. The inclination angle with the direction of flow, it should be in the direction of flow. The angle should be less than 30 degrees. The sample volume should be small to avoid the background noise. A low vessel wall filter should be used. Now, what is a wall filter? Wall filter is a barrier defined by a specific threshold frequency below which the signals are not displayed in the waveform. It's a threshold. Frequency below that threshold will not be on your waveform. So it will be cancelled. You cannot see it. Okay. So you have to set a low vessel wall filter, preferably between 50 to 60 Hz. A fast sweep speed, 4 to 6 cardiac cycles should be visible on your waveform, and you should adjust your PRF. What is PRF? PRF is pulse repetition frequency, also known as scale. It is the frequency at which the ultrasound signals are emitted. A low PRF allows signals from slow-moving targets to reach the probe before the next pulse is emitted, and vice versa for a high PRF. A high PRF will allow high high frequency pulses to reach the probe and omit the low frequency pulses. So that is that. Next, on a color Doppler, for better resolution, smaller color box should be used. It will give you a precise color fill. Again, PRF should be optimized. And for power Doppler is sensitive for lower velocities. Organs that have low velocities, low flows we can use power Doppler to see the color flow in it. Power Doppler detects change in amplitude, unlike color and spectral that detect change in frequency. Power Doppler detects change in amplitude of signal. That's why we don't have the color blue and red in power. We have one color with different shades of different hues of that color, orange color with different hues of it. That is different amplitudes of the color. Okay. There is no aliasing in power Doppler. Gain should be reduced to prevent amplification of noise. Now, I just use the word aliasing. What is aliasing? Aliasing, is defined as if a second pulse is sent before the first is received. The receiver cannot discriminate between the reflected signal from both the pulses and aliasing occurs. It is an artifact when Doppler frequency exceeds the Nyquist limit. What is the Nyquist limit? Nyquist limit, it represents the maximal Doppler shift frequency that can be correctly measured without resulting in aliasing. It, it is defined as
ಏನ್ ಮಾಡ್ತೀರಿ ಏನ್ ಅಡಿಗೆ ಏನ್ ಮಾಡ್ತೀರಿ ಮತ್ತಾಯ್ತು
yeah. So Nyquist limit is PRF divided by 2. So I'll repeat it again. Nyquist limit is defined it represents the maximal Doppler shift frequency that can be correctly measured without aliasing. So PRF divided by 2. If the blood velocity exceeds this limit, the device will incorrectly register the direction and velocity of flow, resulting in aliasing artifact. So I'll show you an example. So I'll show you an example. Imagine you are at a depth of 3 centimeters in the screen. Okay, 3 centimeters. The calculated Nyquist limit comes around 12.8 hertz. And this is calculated. This is again physics behind it, and I'll not go into that. I would recommend you all to just see a YouTube video for it and understand that how I calculated it. So now now we have two probes, right? So the two probes we have are linear and a curvilinear probe. Okay. The linear probe has a frequency of 12 megahertz. Curvilinear has a frequency of 4 megahertz. The angle of inclination should be 0 at angle 0 degrees. At angle 0 degrees. Okay. We have the formula for Doppler shift, that is frequency of the probe into the velocity of the blood into the angle by speed of sound. So by that we calculate Doppler shift to be 23.4 kilohertz, and here the shift comes as 7.8 kilohertz. Okay, so this is 12.8, this is 23.4, this is 7.8 kilohertz. So any velocity with a linear probe, when we are doing Doppler, if velocity exceeds this, I mean, we get this velocity, so we definitely get aliasing here. With a curvilinear probe, our Doppler shifts calculated is 7.8. This is 12.8. So it's less than a Nyquist limit. Therefore, there is no aliasing. So that is how the type of probe is helps in removing the aliasing. That was thing. I really hope you guys understood it. Okay, so basically when when the depth is increased, the PRF is decreased, Nyquist limit is decreased, the likelihood of aliasing is decreased. The waveform analysis of blood velocimetry. So a waveform, what we see on the color Doppler or spectral Doppler, has a peak systolic velocity, a end diastolic velocity, a velocity mean that is calculated by the machines itself. Now our important things that we calculate. The PI, or the pulsatility index. It is also known as Gosling's index. It is a dimensionless parameter. It's a ratio. It is directly proportional to distance between V max and V minimum, which in other words is peak systolic velocity and end diastolic velocity. It is inversely proportional to velocity, mean velocity. It is the intrinsic property of the cardiovascular system governed by resistance difference across the arterial bed. This resistance difference allows the potential energy stored in the elastic proximal arteries to propagate throughout the microcirculation. So this is how you calculate PI. PI is PSV minus EDV by velocity mean. Our next parameter is resistive index, also known as the Percelot index, named after a scientist. It is a calculated flow parameter calculated for maximum, minimum, and mean Doppler frequency shifts during a defined cycle. It is proportional to vascular resistance and compliance. So the main thing that everyone should remember is this sentence. When a vessel narrows, the resistance to flow increases, blood flow decreases, RI increases. So basically, in this example, you can see a narrow blood vessel without any stenosis. I'm just explaining what is RI. So we get a normal good curve, a good nice PSV and nice EDV with a normal RI. And RI depends on the vessel on the organ that the vessel supplies. So blood vessels supplying to vital organs like ICA, hepatic, renal, testicular, and placental have a low RI, like 0.5 to 0.7. Why? Because it needs continuous supply of blood. The end diastolic flow should be more, so that the organ receives the blood that it needs. So RI is low. Bloods that supply to extremities don't often require continuous flow. Only when it's in action, when the organ is on, that is when they need it. For example, ECA, external iliac, SMA, and IMA in fasting. So when we are fasting, our gut does not require that amount of blood. So it is distributed all over the body except the gut. In postprandial, all the blood goes to the splanchnic arteries, and hence the blood flow converts to a continuous waveform rather than a high velocity waveform. So when the probe, now we have a vessel with a stenosis. A downstream stenosis is when a probe is placed proximal to the stenosis. So in this case, the PSV slightly decreases, EDV increases more than the PSV, resulting in increase in the RI. So downstream, in the case of a downstream stenosis, you get a higher RI. That should be more than 0.7. Imagine, it should be more than 0.7. Okay. At the point of stenosis, we get highly increased PSV and EDV. And in the upstream stenosis, when the probe is distal to the stenosis, our PSV decreases more than EDV, resulting in a decreased RI, also known as the Parvus-Tardis waveform. Now, imagine I just told you RI increases to 0.8. Here RI decreases to 0.4. That is an example. Hypothetically, I'm speaking. You get a Parvus-Tardis waveform. So these indices are relatively angle independent and therefore easily applied to clinical practice. None of the indices is superior to the other, and any index can be used. If end diastolic flow is absent, PI is the only index making some sense, because in this situation, S by D will become infinite and RI will become 1. PI is more complex because it requires the calculation of the V mean, but modern machines provide those values in real time. So we are done with Doppler physics. I hope you all understood it. Now let's go to the fetal placental circulation. Fetal placental circulation. Everyone should know this by heart. How the flow is in the fetus. So this is just a flow chart. We'll just brush it up. The oxygenated blood in the placenta leaves the placenta via the umbilical vein. Umbilical vein enters by the abdominal insertion, enters the liver, bypasses the liver by joining the left branch of the portal vein. This left branch of portal vein drains into IVC via ductus venosus. Ductus venosus is a small connection between the portal vein and IVC. The pressure, the volume is a small trumpet shape or small well connection. So there's a volume is very high. So that causes this high spurt of blood directly goes into left atrium via the foramen ovale. Because of the high velocity, high pressure in this ductus venosus, the blood directly shunts into the left atrium, left ventricle, aorta, and supplies the coronary and cerebral circulations. Now, the blood coming from SVC, IVC, apart from the ductus venosus, normal IVC from the other organs, enters the right atrium, goes into right ventricle, goes into pulmonary, and from there it shunts, because pulmonary systemic resistance is more than pulmonary vascular resistance is more than systemic resistance. It shunts blood into the aorta, descending aorta via ductus arteriosus, and from there it supplies blood to the torso and extremities. So basically, the blood that the torso receives is the mixed blood. Now blood from the aorta goes into the iliac, internal and external. From the internal iliac, umbilical arteries arise, and from umbilical arteries, it goes back into the placenta. This is your flow chart, and I hope everybody knows this. So a small pathology tidbit. So when there's a decreased uteroplacental perfusion, the first change in the waveform comes in the uterine artery. Decreased uteroplacental perfusion causes decreased fetal perfusion, right? Now we see changes in the umbilical artery. Decreased fetal perfusion will cause fetal hypoxia, leading to changes in the MCA. This causes redistribution of blood supply to vital organs like brain, heart, and adrenals. This causes late decompensation of the heart, changes in the aortic isthmus. After that, there are changes, this cardiac failure and fetal acidosis. Once fetal acidosis sets in, you get an abdominal ductus venosus and umbilical vein waveform. And once that is there, the fetus cannot survive beyond 1 week. So we have reached the Doppler of the first trimester. In the first trimester, the only visual that is important, we do one basic important scan called the NT scan at the time of 11 to 13 plus 6 days. That is when we do the NT scan. NT scan is not just, you just see the NT and okay, NT is normal. That's not how it's done. It's a mini TIFA scan. It's a complete body anomaly scan. 4 important components of NT scan are the NT, nuchal translucency, the nasal bone, ductus venosus, and tricuspid regurgitation. These 4 are very important components of the NT. Please try to see whenever you're doing an NT scan. Pathological changes in the venous flow in a fetal growth restriction are when there's increased placental resistance, there's increased afterload to the right ventricle, leading to right ventricle decompensation, tricuspid regurgitation. This causes back pressure transmitted to the venous system, where in the ductus venosus. So ductus venosus Doppler. Ductus venosus, as you can see in this image, is a connection between the umbilical vein and the inferior vena cava. Umbilical vein joins the left the left branch of portal vein, and that connects the IVC via ductus venosus. Ductus venosus is a small trumpet-shaped connection between umbilical vein and IVC. Ductus venosus develops at 7 weeks of gestation and shows minimal increase in diameter. As a result, diameter of DV is approximately 1/3 of umbilical vein. So as you can see, umbilical vein, 1/3 of umbilical vein, the diameter decreases, cross-section area decreases, the velocity, pressure increases, highly increases. After the first trimester, the blood coming through the umbilical vein accelerates in DV, and this high velocity gets directed towards the left atrium via foramen ovale. It has a very characteristic waveform and a very characteristic sound, like a washing machine sound, like a whoosh sound, a washing machine sound. This image appropriately depicts how the flow is. The high pressure is being pumped into the left atrium via the foramen ovale. The technique. Use color Doppler to localize the site of aliasing between left portal vein and IVC. The best plane is the sagittal plane. Use small sample volume to avoid noise from adjacent PV, IVC, and hepatic veins. Angle of insunation should be less than 30 to maximize Doppler shift to obtain a good waveform. Always keep it less than 60, less than 30, less than 20. You get a very good waveform. Set the filter at the lowest possible frequency and a high sweep speed, 233 centimeters per second, so that the A wave is not obscured. There are three components of the wave: S wave, D wave, and the A wave. So in this image, you can see the waveform. The gate is kept at the ductus venosus, and you can see S, D, and A. S is because of the ventricular systole, D is because of the early diastole, and A is the atrial contraction. This is the normal waveform that you see. S, D, and A waves. So basically, reversal in A cause this is the last vessel that changes during the fetal IUGR. Only when fetal acidosis sets in, you'll see changes in ductus venosus. When reversal of A wave is where you have to say to the gynecologist, the obstetrician, that there's reversal, there's fetal acidosis, and do the necessary intervention. This is how a reversal of A wave looks like. This is your S wave, this is your D wave, and the A wave below the baseline. The fetus cannot survive beyond 1 week after fetal acidosis sets in. The next Doppler is the obstetric Doppler in the second trimester. So here is the main chunk of the topic today. So let's start with the uterine artery Doppler. Uterine artery is a branch of anterior division. It's an anterior division of internal iliac artery originating close to iliac bifurcation at the cervicocorporeal junction. They cross the external iliac arteries on either side at cervicoisthmic junction and divide into ascending and descending branches. The ascending branches further divide into arcuate, radial, and spiral arteries. Indication of uterine artery Doppler. A patient has a previous or present history of preeclampsia or maternal hypertension, diabetes mellitus, vasculopathy, collagen vascular diseases, a previous child with IUGR, unexplained high alpha fetoprotein, or high HCG levels. So examination, the technique. Signal patterns are recorded from the main trunk of uterine artery on either side. The artery is located by sweeping the probe from medial to laterally into the lower outer quadrant of the uterus. It will appear as red encoded vessel coursing towards the uterine fundus. The uterine and external iliac may appear to cross paths, but this phenomena is seen only during pregnancy and results from increased uterine growth, causing lateral shift of both the uterine arteries. This is how you have to search, find, and do your Doppler in this section where you can see the artery crossing the external iliac arteries. You have to place your sample gate 1 centimeters proximal or distal to the bifurcation to get good results. To record the uterine blood flow velocities, the sample volume is placed on the uterine artery approximately 1 to 2 centimeters medial to crossing site. The optimum PRF setting is usually between 4 to 6 kilohertz. A good quality uterine artery spectra can be acquired at an angle of less than 50 and should present a sharp, clear envelope curve. Abnormal umbilical artery Doppler reveals information about fetal side, while abnormal uterine artery Doppler reveals information about the maternal side. Both uterine arteries are assessed just after the crossing. Measurements are taken, and average is taken to avoid biases due to lateral placental implantation, where the PI and RI values are lower on the ipsilateral side. So in a non-pregnant uterine artery, you see a good waveform with a very less end diastolic velocities. A, B, and C is a non-pregnant uterine artery. In pregnancy, the end diastolic velocities increase because you have to increase, it's a continuous waveform. End diastolic velocities increase because you have to increase the blood flow towards the fetus. This is your waveform in the pregnancy. At the start of pregnancy, the uterine signal pattern shows a high pulsatility with a high systolic and low diastolic velocities, in addition to an early diastolic notch. The diastolic notch is present in uterine arteries, but only up to 16 to 18 weeks. Beyond this, if it's present, then it is pathologic. This notch represents the spectral counterpart of incomplete trophoblastic invasion. So basically, starting out the pregnancy, there's incomplete trophoblastic invasion, you're getting a notch. Then as the pregnancy progresses, the trophoblastic invasion is good, it's complete, the notch should disappear. The severity of notching is defined by difference between the lower early and maximum diastolic velocities. Early diastolic notching and reduced or absent diastolic flow is normal in first trimester. So all these findings are normal in first trimester. But endovascular trophoblastic invasion of spiral arteries lead to decrease in placental vascular resistance. So after 16 weeks of gestation, the end diastolic velocities increase with continued gestation, while vascular resistance decreases as the placentation progresses. So you get a low PI, RI, and S by D ratio. A diastolic notch gradually disappears and is not seen after 20 weeks. This is in the first trimester. You see a good notch. You can see the notch in the even second trimester and disappears in the third trimester. Second to third trimester, it disappears. It should disappear. Yes. So in this image, again, you can see a good high resistance velocity waveform in the 8 weeks. And in 22 weeks, you can see a continuous low resistance increase in diastolic velocities. The progressive increase of diastolic flow is a result of normal trophoblastic invasion. And abnormal uterine artery Doppler. Persistence of the diastolic notch, either bilateral or unilateral. Defective trophoblastic invasion leads to increased RIPI. Simultaneous presence of intrasystolic notch reflects an extremely high impedance. High vascular resistance, that is RI more than 0.58 after 23 weeks and PI more than 1.4. RI and PI more than 95th percentile. The uterine S by D ratio should be less than 2.6, but more than 2.6 is again abnormal. Basically, always remember PI should go down as pregnancy advances. So, in a nutshell, bilateral notch with a mean RI of more than 0.5, unilateral notch with a mean RI of 0.6, more than 0.6, absence of notch, but the mean RI is 0.7, more than 0.7. Okay, and another thing is RI more than 0.58 after 26 weeks. So after 26 weeks, your RI should be less than 0.58. S by D more than 2.6 is also abnormal. This is an abnormal uterine artery flow where you can see a notch in early diastole and you can see decrease in diastolic velocity. So this is how, in this image, you can see the spiral arteries should actually dilate as the pregnancy advances to accommodate the flow, the amount of blood that should pass to the fetus. So in this image, there are 4 spiral arteries. Only 2 are dilated, 2 are not, causing increase in placental resistance. This is what is called increased placental resistance, leading to abnormal uteroplacental vascular system. Also, Effect of uterine artery contractions on uterine artery waveform. The end diastolic velocity in uterine arteries are reduced when intrauterine pressure increases. So in this, you can see the peak of the red wave is the peak of the contraction, where you can see the end diastolic velocity is reduced. In the interval between the contractions, the end diastolic velocity comes to normal. Uses of uterine artery Doppler. It is used in vitro fertilization if the patient's uterine artery PI is more than 3, a very low chance of achieving pregnancy. This tells us about receptivity of endometrium for implantation. The risk factors of preeclampsia and IUGR can be assessed. If the PI of both uterine arteries are normal, the patient can be informed that she is most likely will not develop preeclampsia or have an IUGR fetus, as there is more than 99% of negative predictive value. That helps. The next artery that will be studying is the umbilical artery Doppler. Umbilical arteries arise from the internal iliac artery of the fetus, course along the umbilical cord in a long and winding path to reach the placenta. Intraplacentally, they branch into primary stem villus arteries, which in turn branch into secondary and tertiary stem villus vessels. The tertiary stem villi form the vascular bed of the umbilical artery. As the pregnancy advances, there is increase in the tertiary villi and small muscular arteries, leading to decrease in the placental vascular bed resistance. So I have an image here. Okay. Or uses of umbilical artery Doppler. It plays a vital role in diagnosis of fetal cardiac defects, assessment of hemodynamic responses to fetal hypoxia and anemia. So in this image, you can see small muscular spiral arteries normally look like that. But as the pregnancy progresses, these muscular arteries dilate to accommodate the blood and causing increased blood flow, decreased resistance, decreased RI. Technique to measure the umbilical artery. There's a significant difference in the Doppler indices measured at the fetal end, that is the abdominal insertion, in the free loop, and at the placental end of the umbilical cord. The impedance is the highest at the fetal end, abdominal end, and therefore absent or reversed end diastolic velocity is likely to be seen here first. For convenience sake, we measure from the free loop, free cord. But in multiple pregnancies like twins, triplets, it's better to take measurements at or close to the abdominal insertion to get the perfect waveform. The angle of inclination is not crucial, as all the indices are ratios, I told you before, but angle close to 0 will result in a Doppler shift with the best Doppler shift and waveform. In this image, the umbilical arteries arise from the allantoic arteries. Early in the up till 12 weeks of gestation, there is end diastolic blood flow. This is normal in the early gestation and diastolic, but later on it becomes pathological. Between 12 to 14 weeks, the end diastolic flow develops. Beyond 14 weeks, end diastolic flow progressively increases. So again, as pregnancy advances, there's increase in diastolic flow, increased blood flow meaning RI is low. This is how you sample the umbilical cord. You get a characteristic sawtooth appearance of the arterial flow in one direction. With advancing gestation, umbilical artery Doppler waveforms demonstrate a progressive rise in end diastolic velocity and a decrease in PI. PI in second trimester should be around 2 to 1.5. PI in third trimester should be around 1.5 to 1. The S by D ratio also decreases as pregnancy advances. So before 28 weeks, it should be less than 5. From 38 week onwards to term, it should be less than 3. It should be less than 3. Abnormal umbilical artery waveform. Occlusion of tertiary villus arteries can occur due to thrombosis, fibrinous necrosis, and edema. Decreased number of small muscular arteries lead to asymmetric IUGR. But why is umbilical artery Doppler not used as a screening test for IUGR? Because up to 70% of placental tertiary villi should be affected to show changes in the umbilical artery waveform. But while even only 40% of the villi are affected in IUGR. So 40% may you get IUGR can be present. But the waveform shows changes after 70% is destroyed. An abnormal waveform. Abnormal waveform constitutes a low diastolic flow, meaning high resistance, above 95th percentile, absent end diastolic flow, or a reverse end diastolic flow. The above three are indication of increasing resistance which correlates with fetal hypoxia. In IUGR, defective trophoblastic invasion of vessels leads to increased placental resistance, leads to decreased flow in umbilical artery, decreased diastolic flow. So S by D, PI, and RI, all the indices increase. So this is how a normal waveform of umbilical artery looks. This is the absent end diastolic velocity. This is an example of the reversed end diastolic velocity. And this is the variation in the waveform with fetal breathing. You get variation of the waveform, like a phasic up and down. This is because of the fetal breathing and movements. Umbilical artery, RI, more than 0.8. Once you get 0.8, 0.9, it is abnormal at any gestational age. No matter it's early, it's late, it's mid, RI more than 0.8 is always abnormal. Then I have just told all these things. Okay. This is an image of an absent end diastolic flow, where you don't see any diastolic flow. It reaches the baseline and then stops. This is an image of the reverse of end diastolic flow, reversal of end diastolic flow, where you can see a wave form below the baseline. The pitfalls. Fetal movements and fetal breathing will induce a high beat-to-beat variability. Common sources of error are too low inclination angle, higher wall filter, poorly defined waveform, or heart rate outside normal limits. Transient absent end diastolic flow may be due to cord compression or due to myometrial contractions. Changing patient's position or examination after some time can show a normal Doppler. This is during the dramatic variations during the fetal breathing. The umbilical vein flow is also phasic. The tracing was normal after the breathing stopped. So Doppler of umbilical artery is relatively a crude index of placental health and becomes abnormal when large amounts of placental arteries are obliterated, more than 70%. So how do you treat? What is the treatment protocol is? If there's a decrease in EDV, we have to advise weekly Doppler, and delivery should be done at 37 weeks. If it's absent or reverse end diastolic flow, repeat Doppler 2-3 times a week along with steroid therapy, and still you have an absent end diastolic flow, you go for delivery beyond 34 weeks, and if it's reversed, delivery immediately after 32 weeks. So our next artery is the middle cerebral artery. So middle cerebral artery is a branch of internal carotid artery, and it forms a circle of Willis, as we all know. So this is the image of a circle of Willis along with ACA, MCA, PCA. And you can even see thalamus in this picture. So this is the image of circle of Willis. This is the ultrasound beam at the mastoid temporal window where you can see the circle of Willis. So in this, you can see a circle of Willis again, a very prominent artery, MCA. But why do we choose MCA? Did anyone think why not ACA, why not PCA? Why just MCA? So MCA is the vessel of choice because it is easy to identify, highly reproducible, can be easily studied with an angle of 0 degrees, providing information on the true velocity of the blood. It carries 80% of the blood flow. This is the main branch of circle of Willis. Again, it is easy to repeat and easy to identify because you can see how bright and how beautiful it is looking in this picture. The technique. The MCA is easily visualized in a transverse plane. First, the fetal head is imaged in the standard biometric BPD plane, and then the plane is shifted downwards towards the skull base at the level of sphenoid bones. This brings in view circle of Willis. Place the cursor close to the origin of MCA or proximal third portion of the vessel. The angle of inclination should be 0. Do not use angle correction. Take several measurements from each side with at least 15-30 waveforms. Don't average the measurements. Just take several measurements, and the best that you get, you can use that and repeat the same on the other side. Take several measurements, the best that you get, use that, take an average for precise result. This is how a normal impedance to flow in first trimester looks like, and a normal impedance to flow in the second trimester in an MCA artery. Unlike uterine and umbilical artery vascular beds, which constantly change with advancing gestational age, the MCA vascular bed resistance is almost constant throughout pregnancy. RI is constant. RI is 0.7 to 0.85. MCA is more sensitive to hypoxia than umbilical artery. MCA response to fetal hypoxia is instant. High systole in MCA leads to can give a clue about fetal anemia. High diastole in MCA gives us an idea about brain sparing effect in fetal hypoxia. So what is the cerebroplacental ratio, CPR? It is a predictor of adverse pregnancy outcome in both SGA and AGA fetuses. The index will reflect mild increase in placental resistance with mild reduction in the fetal brain vascular resistance. An abnormal CPR reflects redistribution of cardiac output to the cerebral circulation and has been associated with intrapartum fetal distress. The CPR that is calculated as MCA pulsatility index by umbilical artery PI. An abnormal CPR may result because of an abnormal MCA and normal umbilical artery PI, abnormal MCA and a high umbilical artery PI. In normal fetus, the placental vascular resistance decreases as pregnancy advances. We got that point. We understood that point. Whereas the MCA resistance is almost constant. So S by D ratio of MCA should always be more than S by D ratio of umbilical artery. MCA RI decreases and umbilical RI decreases, leading to CPR less than 1, indicating high fetal hypoxia. In IUGR, hypoxia leads to activation of autoregulatory compensatory mechanisms, cause constriction of the splanchnic, renal, and pulmonary vascular beds with redistribution of 70% of arterial blood flow to the cerebrum, myocardium, and adrenals. This is reflected in MCS as increased diastolic flow with reduced RI. This is the brain sparing effect of fetal hypoxia. The cerebral arteries tend to become dilated in order to preserve the blood flow to the brain, and the S by D ratio will decrease due to increase in diastolic flow. D increases, so S by D ratio will decrease. Autoregulation leads to increase in PSV, increase in diastolic flow, decrease in MCA S by D ratio, PI and RI values. Umbilical artery S by D ratio increases as placental resistance increases. It is a normal waveform, PI, at 36 weeks of gestation. You can see in the image next to it, the end diastolic velocity is increased and this reduced PI. PI has become 1.2. This waveform is known as the brain sparing effect, characterized by increased end diastolic flow velocities. Apparent improvement in MCA, PI, and S by D ratio following sustained hypoxia may occur due to brain edema and reversal of head sparing pattern. So prediction of perinatal mortality is better done via MCA PSV rather than PI, as PSV shows sustained increase and tends to show slight decrease, but values are maintained well above the upper limit of normal until few hours before delivery or fetal demise. Simultaneous improvement of umbilical artery tracing towards normal is a better indicator. So what are the errors in MCA PSV measurement? One is measuring the wrong vessel only. Then is wrong angle. Try to keep it as straight as possible, as parallel to your ultrasound probe as possible. And fetal breathing also affects the measurement. The last artery that we will discuss today is the thoracic aorta or the aortic isthmus. Aortic isthmus is the place where the aortic arch joins the descending aorta via ductus, just proximal to ductus arteriosus, basically. It is the place just proximal to ductus arteriosus, just distal to the left subclavian artery. This is your isthmus, aortic isthmus. Acidosis causes peripheral arterial spasm, rises PI of femoral arteries, consequently increases thoracic aorta PI. If fetal acidosis has intrinsic cause, it will be expected that the femoral artery will be affected more than the umbilical artery. Waveforms from the fetal descending aorta are usually recorded at the level of diaphragm. The PI is the preferred measurement in the descending aorta because EDF may be absent in normal fetuses. This is how our waveform is. You can see the PI of the descending aorta remains relatively constant throughout the gestation because placental and renal resistance decreases while lower extremity vascular resistance increases with advancing gestation. It's normal for diastolic flow to decline at the end of pregnancy, known as the term effect. In severe IUGR, there is reverse flow in descending aorta. You can see the reversal of flow in the descending aorta. This is severe IUGR. This is usually not done. You guys can start practicing on your patients just to get the hang of it. So, in conclusion, the best predictor of fetal hypoxia is PI of MCA. The best predictor of fetal acidemia is PI of thoracic aorta. Reverse flow in umbilical artery, along with pathological waveform in the venous system, are best predictor of severe fetal distress. So, terminal hypoxia. Thank you for bearing with me. I hope you all enjoyed and understood something or the other. Thank you so much, sir.
Thank you, Dr. Asna. Thank you very much for an extensive lecture and lucid presentation. I think she has
Thank you.
covered everything. What we need to have now is case situations in different types of early onset IUGR and late onset IUGR. This itself will take a longer time. So what I thought was, since many of the juniors have also joined, so if you have any doubts in this particular lecture, particularly the physics and particularly the techniques and all, if you have any doubts, you please send message to us, questions to us. So we'll discuss these things again and then go for the particular case situations in which Doppler should be used at what particular in the early onset and the late onset. So we'll have a different lectures, 2-3 lectures for this Doppler, because this is a little complicated. Unless so we don't need to go into the much details of the physics. Once you start using Doppler, it becomes easier, of course. But to understand the Doppler and application, and then at that particular situation where there is early onset IUGR and late onset IUGR, at that particular situation, which artery to be used, and the advice, what advice to be given to the clinician, and to take a major decision, how frequently we should do the Dopplers, and how to interpret the Dopplers at that particular age. If the fetus is low birth weight fetus, less than 30 weeks, more than 30 weeks, more than 34 weeks, so we need different situations to discuss in detail. So what I request is, please go through the Doppler physics and today's lecture, and send me the messages, what questions and what clarification you would like. So probably we'll discuss very soon and then clarify the doubts and go ahead with the particular case situations. So I thank each and everyone for joining. We'll come back with the more clarifications of the this complicated, very commonly used techniques for assessing intrauterine growth retardation, FGR. Thank you very much.
Thank you, sir, for the opportunity.